afternoon or evening, depending on where you are, or morning. Welcome to our Global Health Learning Network for April. My name is Manisha Kulkarni. I'm the Assistant Dean of Global Health in the Faculty of Medicine at the University of Ottawa and an Associate Professor in the School of Epidemiology and Public Health. We're here today with a great speaker, Dr. Amber Hoy, who will be talking about the impacts of the COVID-19 pandemic on malaria burden and malaria control in Benin, evidence from mathematical models and mixed methods. Before we get started, I would like to share our Indigenous affirmation. If you could change to the next slide, Olfa. We pay respect to the Algonquin people who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. Our Global Health Learning Network is a platform for knowledge growth and exchange with the goal to build a community of practice in global health that reaches researchers, practitioners, and learners from all global health domains. And as part of the Learning Network, this webinar series is a collaboration between the School of Epidemiology and Public Health at the University of Ottawa, the Briere Research Institute, the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment in Health Equity, and the International and Global Health Office in the Faculty of Medicine. Today we have Dr. Amber Hoy, who is a data scientist and theoretician broadly interested in vector ecology and parasite evolution. She completed her BSc in biology and MSc in epidemiology at Simon Fraser University, and later her PhD at the University of Toronto in ecology and evolutionary biology. Amber is currently a postdoctoral fellow working in the Insight Lab, which is my lab in the School of Epidemiology and Public Health here at the University of Ottawa. And she's been a member of the research team for this IDRC-funded project looking at the impacts of the COVID-19 pandemic on malaria burden and control in Benin with partners at University of Ottawa, the London School of Hygiene Tropical Medicine, the Centre de Recherche Entomologique de Cotonou, CREC, and Dalhousie University. And with World Malaria Day taking place just earlier this week on the 25th of April, we thought this would be a really relevant topic to highlight for this webinar event. Just before I pass it over to you, Dr. Hoy, I would just like to welcome some of our team members. We have Dr. Manfred Akrambesi from the London School, who's based in Benin. Welcome, Manfred. And as well as Cindy Feng from Dalhousie University, and hopefully some of our other colleagues from Benin will join us as well over the course of the talk. So without further ado, I will pass it over to you, Dr. Hoy, to share your screen and presentation.
Hello, are you able to all see my screen all right?
Yes, looks good.
All right, great. Whoops. Sorry, I'm just still organizing my screen because no matter how many times you do an online presentation, it's always a button seems to move around. But all right, yeah, hello everyone. Thank you all for coming. Thank you, Manisha, for that introduction. So today I'm going to share with you this recent project that our group have done that looked at the impacts of COVID pandemic on malaria burden and control in Benin. So pulling together evidence from mathematical models and mixed methods research. As mentioned, I want to start off by saying that this project is part of a large international collaboration between these institutions and researchers, and I'm merely presenting on behalf of the team. Parts of the results I'll be showing you today has also been currently in press at PLOS Global Public Health. It should show up on the website any time now, so please do check it out if you are interested. All right, so as most of you are probably familiar, malaria is endemic in many sub-Saharan African countries, where concerted disease control campaigns have resulted in the steady decrease of burden over the past 2 decades. However, progress towards elimination in sub-Saharan Africa has slowed and stalled since 2015. That's this blue line over here. That's falling short of the WHO strategy for malaria milestones. That's supposed to be this green line over here. Now, the COVID-19 pandemic may further hinder this progress for a variety of reasons. So for example, it was feared that resources will be pulled away from malaria towards COVID control. Health facilities may become inundated with COVID-19 patients. There could also be some avoidance behavior on this side of the community members. And so at the beginning of the pandemic, with all these potential negative impacts looming, we really needed a way to help us quickly figure out just what that impact would be on malaria burden. And so at this time, researchers turned to mathematical models to help us with that. And before we get into what we learned from models or what these models are, first I'm just going to briefly talk about what is a model. So you may be familiar with models in the sense that they are conceptual tools that explain how an object or a system behaves. A mathematical model takes these concepts and expresses them in math and equations so that we can have a more refined and precise description of the behavior or of the object or of the system. And so if we're to imagine a case like a model of filling a bucket with water, we would come up with this kind of mental image. And if we're going to write a mathematical model based on this, then we would write the water in a bucket is equal to the amount of water in minus the amount of water coming out. And mathematical models have 2 distinct roles, and we can think of it. So they're predicting and for understanding. So firstly, models can help us make predictions on likely future events or outcomes by analyzing patterns in a given set of input data and using that information to forecast into the future. This type of model is very useful, especially in guiding difficult policy decisions where there could be a trade-off between 2 or more alternative control strategies. And because when we do predictions, well, of course, we want to be very accurate. Accuracy is a good thing. And so predictive models tend to be very complex because we want to include lots and lots of details on population level variation. Models can also be used to help us understand how infectious diseases spread in the real world and how various complexities affect its dynamics. So you can imagine this as a scenario as providing epidemiologists with like an ideal world where we can like fiddle with like individual factors and examine each of them and their impacts on disease and isolation. So kind of like playing a video game, except that we're learning something about disease spread when we do so. And epidemiologists have been using these models to help understand disease dynamics and factors that influence them for a very long time. Some of the earliest disease modeling work date back to the early 1900s when mathematical models were developed by Ross to better understand malaria transmission. So these models were later refined by McDonald, and they are still used very widely today. And so, so these models can be broadly categorized as compartmental models. And to give you an idea of how these models work, so if we go back to the water in bucket analogy, so here we could imagine that the waters are people and the buckets are compartments that will hold the water or the individuals. And let's say we have a bucket for people who are susceptible or not sick. And so how much water in each bucket would depend on the input. So for example, in this case, we would imagine that is like people are being born. And it will also depend on the output. And that would be, in this case, could be infections. So when people become sick, they no longer, they leave the susceptible bucket. And if we were to write this in math, we would write susceptible people will equals to births minus infections. We can then imagine there being another bucket that catches all the water that flows up on this top one. This bucket would hold all the infected people. And so the input, infected, and the output in this case, we think of are people recovering from the illness. And so again, in math, we would write infected people would equal to infections minus recovery. And actually, if we can just bend physics in your mind a little bit, you'll see that actually these recovered individuals would return to the susceptibility class. And so they have the possibility of becoming sick again, right? So we could add this term back to the susceptible equation here. So this has been a very simple depiction of how such a model is built and how they function. We can imagine adding more and more complexity onto this, either by adding more processes, such as like depths, or more buckets and compartments, such as people who are immune. But there's also a movement towards developing new class of models that can handle complexity better, especially now that computers are so much more powerful. We can incorporate a whole lot more detail and variation at the level of individuals to help us achieve better predictions. An agent-based model is one such type of model that allows us to explicitly track the states of individuals or agents in it over time. And they are particularly useful for questions where individual variability, local interaction, and adaptive behavior are essential to making accurate predictions. So if we compare to our previous example of tracking buckets and the amount of water in them, with an agent-based model, what we'll be doing is we're tracking each individual drop of water and its properties, such as, you can imagine, like its size, and in human terms, that could be like the age of an individual, and where it is or which bucket it is, so whether the individual is sick or not. And here, with an agent-based model, instead of writing one equation for each bucket, we would write one for every individual we simulate with our model. So you can see that these models are complex. They take a lot of computing power to work with, but they are very useful. And these will be the types of models that we're going to be using today, later on in our project. All right, okay, so enough with buckets and waters. Now let's get back to malaria. So in the early days of the pandemic, a couple of studies used these agent-based models to try to understand the potential impacts of COVID-19 on malaria burden in sub-Saharan Africa, and all of them paint a pretty grim outlook for malaria. So for example, this study estimates that in the worst case scenario where all malaria interventions, including national bed net distribution campaigns, access to treatment, everything that's all halted for 6 months, we could see up to 350,000 additional deaths across sub-Saharan Africa in 2020, doubling 2019 levels. However, most of these early models are also constructed at the scale of countries, which may not be a good representation of local disease epidemiology and responses. They're also based on assumptions of what may happen, but now, of course, as time went by, we have the opportunity to go in and investigate what actually happened. And so our models are due for updates. And so we conducted this study to first update our COVID and malaria models to the relevant scale and with up-to-date and local information, and also to try to better understand the nuanced impact of COVID on malaria control at various levels of the health system and also at the community level from the perspective of individual behavior. This study takes place in the West African country of Benin. in 3 rural communes in the Seoul province. This area is composed of 123 villages with approximately 40,000 households and 191,000 inhabitants. Malaria is highly endemic in this area with some seasonality in the transmission cycle. Here's what a typical village looked like in Kobe, one of the study communes. All right, so now I'm going to tell you about the first component of the project, which is modeling malaria. So again, we used an agent-based model for this purpose. So that's the type that tracks every single drop of water in the buckets. The model that we use was originally formulated by Griffin and others, and it's described in full in this paper over here. And it's also been made into an R package called Malaria Simulation, and it's available via GitHub. So briefly, in our model, we simulated a population of 20,000 individuals and tracked what happened to each of them over time. The states or properties that we were interested in tracking were age, immunity level, which individuals will gain at birth and through repeated exposures to malaria throughout their life, treatment and BETnet protection status, and also infection status, which is further subdivided into these categories, which the individual may either recover from or die from. And the rate at which individuals are exposed to malaria is determined by the local mosquito density, which depends predominantly on rainfall. And so we can keep track of this population and all its agents in it over time. And at any point in the simulation, we can tally up all the agents and their states to calculate population level epidemiological matrices, such as prevalence and incidence. Okay, so what did we do with this model? So first, we're going to figure out a baseline model and then simulate the disruptions that happened, focusing on 2 types of malaria interventions, and those are the BETnets and treatment access. In terms of BETnets, we know that actually most of the planned BETnet distribution campaigns in sub-Saharan Africa were completed successfully with only some delays. And in fact, most of these campaigns became digitized, with a new distribution strategy, and was actually piloted in Benin. You can find more details in this paper. Now, this paper also came with a very handy table, this one over here. And so we could look up our province and found that BETnet coverage is estimated at 95%. So that's great number for our model. Now, in terms of treatment access, this is an area we really didn't have good information going into the project, but what we expect to learn more from the objective 2. And so for now, we're going to take a sensitivity analysis approach and investigate the effect of treatment disruptions of varying severity and duration on malaria burden. So with all of that in mind, we've decided to formulate our baseline scenario as one where the BETnet campaigns went ahead with a slightly delayed timeline, achieving that 95% coverage. And we're going to focus on trying to understand the effects of various forms of treatment disruption in that context. All right, and now onto some results. So this figure shows the effect of duration of treatment disruption, which we assume to begin on March 1st, 2020, on point malaria prevalence estimate in all the study population across 5 different levels of disruption compared with the baseline of no disruption. And in all of these scenarios, again, the BETnet campaign plan for Benin in March 2020 was completed with a slightly delayed timeline. And so here what we see is that so prolonged and severe treatment disruptions are not good for malaria. Thus, there's no surprise there. The effects of prolonged disruptions becomes more apparent as the disruptions become more severe. And when compared with the baseline model, malaria prevalence was estimated to increase by about 3 to 4% in the worst case scenario where treatment was disrupted completely for 6 months. And here I've plotted out the full time series so we could look at the dynamics more closely. We have the year 2020 on the x-axis and malaria prevalence on the y-axis for both of these figures. And on the left here, we see that as we increase severity level, malaria prevalence goes up, and we're shifting the entire curve upwards. Whereas in contrast, when disruption duration is prolonged, we see that a new peak in prevalence emerged sort of later in the year. And on both of these figures, I've also marked on this dashed line, which is a cross-sectional survey we've conducted in our study sites, where the point malaria prevalence was estimated and it's marked by this red cross. So we can see that in both cases, the observed value is lower than model estimates, which is very good news for the local population. And I'm happy to talk about this a bit more in the discussion period if anybody is interested. All right, now let's move on to the second half of the project, where the objective is to understand the nuanced impact of COVID-19 on malaria prevalence and control at the health system and community levels. So this part of the project consists of a couple of components spanning 3 levels of the health system down to the general public. On the health system side, we conducted semi-structured interviews with key informants. So these are the individuals who play key roles in malaria control in Benin, which include authorities at the Ministry of Health, managers at hospitals, physicians and nurses, and community relays. And we asked these informants on their roles in malaria control and how their work has been impacted by the pandemic. And at the community level, we conducted knowledge, attitude, and practice, or CAP surveys, which were aimed at assessing the surveyed individual, in this case, heads of household, on their COVID knowledge, and whether their bed and treatment access has been affected by the pandemic. The CAP surveys were then followed up with more free-formed focus group discussions to provide more context for the CAP survey results. Okay, so here's a summary of what we learned from all the surveys and interviews and focus group discussions. So first, some general COVID response measures on the health system side. And these include the creation of independent COVID-19 management centers, separating COVID-19 care and other health services. There was a lot of effort put into training personnel on COVID knowledge and providing all staff with PPE, as well as establishing community brigades in each village who are tasked with sensitizing their communities and ensuring preventative measures were followed. In terms of malaria control, we see a couple of negative aspects of that due to COVID-19. Well, first, they were unable to expand their healthcare staffing in time. And so existing workers had to pick up extra tasks related to COVID control. Some doctors mentioned that some of their patients weren't going to health centers at the beginning of the pandemic. And I just want to mention that this can be conceptualized as a form of treatment disruption, like what we have in the model. And lastly, and slightly unexpected, there was confusion over the use of chloroquine as treatment for both COVID and malaria. And so chloroquine was phased out as malaria treatment in Benin in recent years due to the emergence of resistance, but was reintroduced into the country when disinformation spread about its efficacy against COVID. And so when people see it back on the shelves, they bought it for malaria out of familiarity. But the situation is not all negative. Turns out there were some unexpected positives as well. So for example, physical meetings were shifted online, which saved time and money on traveling. Malaria prevention information sessions that used to be large group gatherings got replaced by home visits from community health workers, which improved communication, and the health workers were also able to check on proper usage of bed nets, as well as follow up on malaria cases. And lastly, as previously mentioned, the digitized bed net distribution campaign, which used a door-to-door distribution model, resulted in improved bed net coverage in the country. Okay, now let's zoom in on the community level and look at actual bed net usage and healthcare access during this time. So the CAP surveys revealed that 73% of the target population had access to bed nets. Now, you may notice that these numbers are lower than the provincial level estimates of 90 to 95% that I showed you previously. And the focus group discussions was able to provide some insight on why there was a discrepancy. So it turns out that people were practicing social distancing very, very diligently, even in their own homes. And so they were no longer sharing beds and therefore no longer sharing bed nets, which potentially resulted in this shortfall of bed net access. In terms of treatment access, so 19% of CAP respondents said they avoided health centers during the pandemic. And so at this point, you might be thinking, yeah, that's it. This is the number that we've been looking for. I should go back to the model results to that figure and find the minus 20% line, and that's the answer. But no, actually not that fast. Because once again, the focus group discussions provided more context on the number, and it was revealed that actually health-seeking behavior has been quite polarizing in that while some people are avoiding the health centers, there are also quite a few people that is now seeking care more frequently, precisely because they are scared of COVID. And so they will go to health centers and get tested a bunch. It also seems like this sort of polarizing behavior already existed pre-pandemic. So some people like to go to health centers because they're scared of illness and death, while others avoided health centers because they think it's too expensive and they don't have the time and resources to go there. So that wraps up the summary. I hope I've highlighted for you the utility of mixed methods research, especially how mathematical models and qualitative surveys can complement each other. This project also demonstrates the importance of top-down leadership in maintaining essential health services, especially in helping to set up local programs that mobilize community members to disseminate information and to educate each other. And also that we need to be extra cautious when disseminating information during health emergencies. Accessible and audible sources of information are effective channels to disseminate novel and salient information during health emergencies, but information can also be easily misinterpreted, and also disinformation can spread just as easily. And with that, I'd like to acknowledge the contributions of all of the co-authors on this project again. Thank you for your attention, and happy to discuss with you further.
Thank you so much for your presentation, Dr. Hoy. Great to see some of the results of the project and highlighting integration of mixed methods research and mathematical models. Just before we open it up for more discussion, I'd like to welcome our other colleagues that have been able to join. Professor Martin Acobeto, who is the country PI in Benin. Welcome, Prof. It's good to see you.
Thank you. Nice to see you.
Good to see you. And I saw that Ludovic is there also with Manfred. So welcome, Ludovic. Ludovic, who led focus group discussions, key informant interviews, and Manfred, who led the cross-sectional surveys in the context of a large malaria project ongoing in the region. Welcome also Professor Jabanu from ERSP in Benin, one of our university partners. So wonderful to see everybody here today. Does anybody have any questions for Dr. Hoy? Perhaps you can just stop sharing your screen, Gigi, and then we can open it up for questions.
Just a comment.
Yes, please go ahead.
Can I go?
Yes, please.
Okay. Thank you very much. Just to say, I would like to thank the University of Ottawa through Professor Manisha, who has involved us in Benin in this interesting investigation. For me, I'm very, very happy to participate to this study. We have learned too much from the University of Ottawa, particularly from Professor Manisha and her students. After the study, we have organized a feedback meeting with the authorities of the Ministry of Health and with the local community of the study area. And I'm very pleased to say everybody has appreciated the study. It was an opportunity for us to understand the level of community COVID-19 and the measure they take to protect them against coronavirus. Once again, I want to say I'm very, very happy to participate to this study. Thank you very much.
Thanks so much, Professor. It was a great pleasure for us to work with you as well. I should also just quickly introduce Claudia Duguay, who's a PhD student who is also from the University of Ottawa, working in this team, contributing to much of the project work as well. So I will open it up for any other questions. Otherwise, we can have more of a discussion in terms of the context around malaria control during the pandemic. So if you do have questions, you can turn on your camera and ask or put up your hand. In the meantime, perhaps a question for you, Amber, but also for other team members who are here is what strategies that were implemented during the pandemic that really successfully mitigated a lot of the negative impacts do you think will be sustained in the future? Do you think that the health system will go back to its previous approaches, or do you think that some of these novel strategies will be sustained? I don't know if you have any thoughts on that. First, Amber, and then perhaps Manfred or Prof. Ecobeto, if you have any thoughts on those topics as well, it would be great to hear.
Yeah, I think this is definitely a question that the members of the local research team would be much better to answer than me. Like I could say, I hope it seems like the Benin distribution that's shifted to a door-to-door distribution model have had quite an important role in like making sure that the campaigns were not canceled. my understanding is that other countries have also adopted similar distribution models after they saw that it was successfully piloted in Benin. And so I hope that aspect can be kept moving forward.
Are there any thoughts from the team in Benin? No,
No, nothing to add. Just to remind that Benin, as well as most of the country in West Africa, were among the countries which are promptly react to the COVID pandemic. As soon as we detect the first case, for instance, in Benin, all the south of Benin were put in quarantine, only leaving people we've had merchandise to traverse the restriction area, and there were also very quick and intensive action from the Ministry of Health. All of these action were very efficient, I mean, but unfortunately we don't have some really informative research evaluation to assess if it's if these actions, which are in fact explain why we have less cases in Benin. But yeah, in fact, this study was very interesting for us because we learned a lot about how the community understand this disease, their behavior about this disease, and we think that we need more evaluation because COVID-19 is not probably will not the only strange diseases which are coming out. So I think we need to prepare, and we need also to prepare ourselves and also prepare the health system in order to mitigate any upcoming, non-known disease. This is what I can add.
yeah, that's really important to highlight that this probably not the last health emergency that we'll be facing. And so it was very impressive to see some of the quick actions that took place really to mitigate the massive impacts that we were expecting on malaria, and through different innovations that were able to be applied. But still some of the issues around health communication and integration across the health system are still ones that we face challenges with for malaria and for other issues as well. Another question I had, and maybe this is more for you, Amber, is more about integrating data sources. How well do you think it works to try to use mathematical models as a tool to understand, potential impacts, and how well can we integrate data from survey data, qualitative data? Is that something that you've seen in other places?
Well, I think mathematical models definitely play very important roles in helping us either predict what's going to happen or helping us understand what did happen. So in the case of today's presentation, we sort of saw a little bit of both of those usages, both at the beginning of the pandemic and sort of what we did to try to better understand. And so utility is great. In terms of data sources, I think that's always the biggest challenge as a modeler, is to find good data, sufficient ways to parameterize the model, because the model is only as good as the assumptions, and we always have to be very careful with that, and be mindful of the risk that I guess model results could be driven by if there's any inaccuracies in the parameterization. And I think For this project, I try to source parameters from like published data. Most of it, I mean, typically is from quantitative research, because with math, ultimately you want to be able to put a number in your model so that you can get numbers back on the other end. But we also see that qualitative surveys could also be co-opted into helping us guide model building decisions. This is not just putting a number in. We also have to consider what types of scenarios we want to work on. So in this case, the qualitative results have shown us that there probably was not a very severe treatment disruption, and it probably happened pretty close towards the beginning of the pandemic. So that helps us narrow down the number of scenarios that we need to consider in our model. And we use then took a sensitivity analysis approach because we were not able to get a precise number of 20%. And so like a mix of those strategies, hopefully use some creative solutions to help us mitigate like the lack of the data.
Great, thanks. Cindy, you have a question?
Thank you very much, Manisha, and thank you, Amber, for your very wonderful presentation, which is very informative. So I just have like a couple questions. The first one is related to the mathematical modeling you presented. So you showed this very nice graph to show the impact of disruption of treatment on the malaria prevalence. And you show the observed prevalence is slightly lower than the simulated one. And it's really great to see your qualitative study actually investigate the possible reasons might be due to the healthcare seeking behavior change or social distancing. So I'm just wondering if in your agent-based modeling, whether it's possible to incorporate some of those, the healthy behavior change or social distancing or the public policy restriction, could that be possible to be incorporated in the model?
Yeah, so that's a great question. So in terms of behavior, so in this model, treatment access is modeled as the joint probability of seeking treatment when sick, and plus the probability of receiving treatment when the person seeks. And in the current iteration of the model, those two factors cannot be separated. But that is a thing that if we want to, so right now, if we want to isolate one of those, but we would, you can still do it, but like implicitly, where it's not explicit separation, because if you multiply, you can imagine a case where if the probability is 50%, it could be 50% of the people sought healthcare and 100% of those people received it, versus some other combination of the probability. So we could investigate that in like sort of implicitly, but not explicitly, because of the way that treatment access is being I guess, formulated into the model.
That's very helpful. And also I have another question. So whether the impact of the treatment disruption on malaria prevalence differs by age groups?
Yeah, so that's also a good question. So we did, in some preliminary studies, did look at the prevalence in children versus all ages. The impact is qualitatively similar, so all the same trends that we see. And I chose to present the all ages malaria for this presentation because that's what we have, that's the data that we have out of the cross-sectional survey from the field was all ages malaria. But model simulation show that the trends of the effects are qualitatively the same for children under 5.
Okay. Yeah. Thank you very much.
Thank you.
Great. Thanks, anyone. Any last questions? We'll try to wrap up at 10 minutes to the hour, and we're almost there. Perhaps just before we go then, I will ask you to complete, there's a survey that will be launched, a Zoom poll that will be launched just to get some feedback on this webinar. And it would be great to have your input to that. Miriam, if you're able to launch that, please do. And I just wanted to say thank you very much to everybody for joining us today. The webinar link will be posted online on YouTube, so it's possible to watch it later on. And I hope you'll be able to join us for our next webinar in May. We'll have Dr. Lawrence Lowe talking about some lessons learned more broadly in Canada about the pandemic, which will be quite interesting to hear about as well. Thanks again, and thank you to all of the project team members who are able to join us today. It's wonderful to see and hear from you, and look forward to being in touch with you again soon. So the poll has been launched. Please do enter your responses, and hope to see you again next month. Thanks, everyone.